While medical fields like orthopedics rely on PRP injections, ophthalmology utilizes a different mechanical approach. Here, the biologic is prepared as topical eye drops, thawed daily and applied directly to the surface of the eye. Intact platelets bind directly to exposed collagen on the damaged epithelial layer. Once adhered, they activate and release a concentrated cloud of growth factors. This biological reservoir provides localized delivery that resists the washing effect of tear fluid, a sustained release synthetic drops cannot achieve. This high-precision delivery targets a massive clinical burden. Dry eye disease affects 344 million people globally, with a significant subpopulation suffering from severe complications like corneal ulcers and persistent epithelial defects that fail to heal with standard care. Clinical guidelines reflect the severity of these cases. The TFOS-DUES treatment ladder explicitly positions blood-derived products like PRP as a Step 3 therapy, reserved for patients who are refractory to artificial tears and prescription anti-inflammatories. This intervention focuses on the high-need segment of the market, the 5 to 10% of patients with severe disease who require a regenerative biological response rather than simple lubrication. Autologous serum has long been the primary Step 3 blood-derived option. However, serum typically requires 20% dilution to lower the risk of side effects, which reduces the concentration of all available healing factors. PRP offers a concentration advantage. It can be applied at 100% undiluted strength, delivering a higher proportional volume of critical proteins to the ocular surface. Dilution is often necessary in serum to limit TGF-beta, a protein that can trigger corneal scarring and fibrosis. Leukocyte-poor PRP contains lower levels of TGF-beta than serum, allowing for a safer healing profile without the need to dilute the product. Head-to-head clinical data supports this transition. The 2024 Zhangke-Zhornpong trial, the largest randomized controlled trial in this field, established non-inferiority between PRP and autologous serum with identical improvements in disease index scores. Analysis of the fluids showed that PRP contains significantly higher levels of epidermal growth factor, basic fibroblast growth factor, and nerve growth factor than serum. While both are clinically effective, PRP provides a mechanical delivery vehicle, intact platelets, carrying a more potent baseline of repair proteins with a reduced scarring risk. The efficacy of these proteins is most evident in treating persistent epithelial defects. These are orphan corneal wounds that remain unhealed after 14 days, often resulting from neurotrophic nerve damage or chemical burns. The current FDA-approved recombinant biologic for these defects is Senogermin, a synthetic drug designed to stimulate nerve repair. Senogermin works through a single mechanism, delivering synthetic nerve growth factor to the target receptor. Autologous PRP provides that same nerve growth factor, but pairs it with EGF, PDGF, and fibronectin to activate multiple healing pathways simultaneously. Clinical benchmarks show the difference. The single-molecule recombinant drug achieved healing rates between 58 and 70%. In comparison, independent case series for PRP consistently show healing rates between 80 and 97%. The cost comparison is just as stark. An 8-week course of the recombinant drug costs over $118,000, while a therapeutic course of autologous PRP can be produced for approximately $300. This multi-target approach has also resolved cases where other blood-derived products failed. In the 2018 Sanchez-Avila study, 5 patients whose defects showed no response to autologous serum successfully achieved complete healing after switching to PRP growth factors. These clinical results suggest that autologous PRP can provide superior real-world healing across various etiologies at a minute fraction of the cost of synthetic biologics. In severe corneal ulcers, the challenge is halting tissue destruction. Even after an infection is cleared, the eye's structural collagen can continue to dissolve. This degradation is driven by matrix metalloproteinases, or MMPs. These enzymes aggressively tear apart the collagen matrix, leading to stromal melting and potential perforation. The body's natural defense is a protein called alpha-2 macroglobulin, or A2M. It acts as a pan-protease synthase inhibitor, neutralizing the enzymes that drive tissue melting. However, the cornea is avascular. It has no blood vessels. Because the A2M molecule is so large, weighing 720 kilodaltons, it is physically unable to cross from the bloodstream into the clear corneal tissue where the damage is occurring. Topical PRP drops provide the mechanical route necessary to solve this problem. Applying the biologic directly to the surface of the eye bypasses the lack of blood vessels, depositing the massive A2M molecules exactly where the enzymes are most active. Once deposited, A2M utilizes a bait and trap mechanism. It physically envelopes and locks down the aggressive enzymes, stopping the melting process and preserving the eye's structural integrity. This topical delivery enables these massive proteins to cross standard biological barriers and reach the damaged avascular tissue directly. Concentrating these proteins into an effective eye drop requires a precise mechanical isolation process, starting from a 24 milliliter blood draw. Systems like the ProSmart 2 use ultrafiltration with a 15 kilodalton molecular weight cutoff. This membrane physically traps and concentrates massive healing proteins like fibronectin, A2M, and nerve growth factor, while removing excess fluid. This process creates a challenge for smaller molecules. Epidermal growth factor weighs only 6.2 kilodaltons, meaning it is small enough to pass right through the filter pores and be lost in the waste fluid. If the filter loses this free-floating growth factor, we would expect the final product to lose its ability to drive cellular repair. But clinical results show the therapy remains highly effective. The reason for this retention is biological. Most of the body's epidermal growth factor is housed inside intact platelets. Because platelets are several micrometers wide, they are vastly larger than the filter pores. They remain trapped above the membrane, keeping their healing payload secure until the drop is applied to the eye. This filtration refines standard PRP into a biological matrix that is specifically concentrated for the requirements of corneal repair. The market context for this intervention is substantial. Of the $6.3 billion spent annually on dry eye treatments, the severe and refractory segment represents an addressable market of up to $630 million. This segment currently relies on prescription anti-inflammatories like cyclosporin, which cost over $700 a month. A single PRP preparation session provides multiple days of treatment, offering a high-efficiency alternative for these chronic cases. While the biological case is strong, the evidence has clear boundaries. Current data is predominantly Level 2 and Level 3, and the field lacks the large-scale Phase 3 randomized trials required for a final regulatory consensus. Safety monitoring is also essential. Because ultrafiltration concentrates all proteins above the weight limit, patients must be monitored for corneal neovascularization, driven by the increased concentration of VEGF. Despite its inclusion in international treatment guidelines, there is currently a void in the market for a standardized PRP device specifically optimized for the ophthalmic space. Matching the clinical outcomes of a six-figure recombinant drug with a $300 autologous preparation provides a clear path for treating high-need patients who were previously limited by cost. Finalizing the clinical evidence for this transition remains the next major hurdle for the field.